Welcome to this morning's session on global public health research in hepatitis. My name is Philippa Easterbrook from the Global Hepatitis Programme at WHO headquarters, and I'll be facilitating this session. Over the last couple of days, we've been talking about country experiences, national planning processes, and some of the issues around these in the parallel sessions. But an additional important contribution of countries is in defining and shaping the research, public health research agenda, and increasingly owning it and sometimes funding it. This is a shortish session, and it's going to be divided into three parts. First, with a scene-setting presentation that will include touching on the role of WHO in setting the research agenda, a quick snapshot of current research funding for hepatitis from selected agencies, and then finishing with a summary of current public health research priorities for hepatitis B and C. And we're then very fortunate to have Claire Rechovich from the French National Agency for Research, which has been very much leading in hepatitis research, including in low-income settings, who will talk about the portfolio of work and also highlight some of the lessons learned. And this will then lead nicely into a panel discussion. And we have a distinguished panel of speakers, all who have been on the podium previously, so you know, Professor Jidong Jaya, so sort of representing academia, John Ward, representing a public health agency, Claire representing a funding agency, and Charles Gore from the World Hepatitis Alliance from the civil society perspective. So moving on, and first of all, what is the role of WHO, if any, in setting the research agenda? WHO is not really an implementer of research, not really a funder of research, although it had or has established in the past two major initiatives that had a significant research function. That's human reproductive health and TDR, the tropical disease research. And there are other departments that have established research agenda roadmaps, particularly in infectious diseases. But there are four key pillars around the WHO approach to research. That is strengthening health systems and capacity, setting priorities according to the local context, and setting standards and norms, and translating evidence into practice, so the implementation science. And underpinning these four pillars are three principles: that of quality, ensuring that the research is conducted in an ethical manner; impact, so aligning the priorities to address local needs; and finally, inclusiveness, so involving local research leadership, civil society, and communities. And certainly it was very striking to me that, during the Ebola crisis, the research agenda was and still is very much dominated by researchers from the north. Well, there have been two sort of very helpful products that one of the useful byproducts of putting together this presentation is discovering sort of reports and initiatives in offices and corridors just next to mine that I was sort of unaware of. So one of these is that there is a research priority checklist developed by WHO, including 9 items that address the methodology of research priority setting. I'm just going to highlight a few of these points. That of the addressing the context that you really is going to underpin the process, the importance of inclusiveness and who will be involved and why, identifying the criteria to focus the discussion around setting priorities, and the many different methods that are out there for ranking and establishing consensus in research priorities. Which one are you going to choose, and how are you going to evaluate the impact of the priorities you've set, and ensuring that there's transparency. An additional very useful product has been this report prepared by TDR on health and research and development for low and middle income settings. I would recommend reading this. There are a number of key recommendations, but one of the particularly interesting one is now the planned establishment of a research and development observatory for health, which will pull together who's doing what where, and was very much in response to member states saying data sharing is poor, we need to have some sort of central repository. This will go live in 2016 in a phased manner and really collate a lot of data from public sources, clinical trial registry, patent information, and published literature. And it really would have been very helpful in my quest to provide you with an overview of research funding for hepatitis to have had access to such a research observatory, because what became rapidly apparent was that unlike in HIV, a lot of the research funding for hepatitis isn't well captured or categorized. The different agencies amass the data and organize it in different ways, so it's very difficult to come up with a total funding for research in hepatitis, compare across agencies or look at temporal trends. But during this process, I looked at just a selected number of perhaps the more traditional research funding agencies. This was by no means comprehensive. I haven't captured the important and emerging research portfolio from industry and implementation science, and did not really capture Australia, Canada, and some other key funding agencies. But I think from this exercise, 3 or 4 key observations. That most of the funding has in the past been going towards basic science, that hepatitis has only a fraction of the funding, research funding that's available for HIV. Funding for hepatitis C is about 2 to 3 times that for hepatitis B. And the increasingly important implementation research is being funded by what you can call the less traditional research funding sources, industry, UNITAID, and this really fantastic initiative, which is the Patient Centered Outcomes Research Institute, which is just now investing 50 million in a series of very implementation-orientated outcomes research. So, just speedily going through a number of snapshots from a research agency, so a very traditional one, very close to home, the Medical Research Council. It's a UK government-funded research organisation, overall research investment per year of 840 million. There are currently 19 live awards in the UK of 15 million in hepatitis, ranging right across the biomedical spectrum from structural biology, viral pathogenesis to applied research. So generally it's about 5 million a year, shown on this bar chart, not much evidence of increase over time. And the investments are made largely through research centres and units based in universities. There's a real flagship one on virology in Glasgow, as well as some of the MRC international units in Gambia and Uganda. What are the global health activities from the MRC? Well, there's about 5 projects in low and middle income countries, total investment about 3.4 million. Just to highlight a couple, the long-standing Gambia hepatitis intervention study, which is looking at the impact of early infant vaccination on hepatocellular carcinoma. So it's a partnership between the Gambia government, the International Agency for Research on Cancer, so WHO agency, and the Medical Research Council unit in the Gambia. And we heard the results presented on day 1. So really major policy implications from their finding, modelling work that's been undertaken at Imperial College, and a number of other projects too. Wellcome Trust, one of the major global funders of global health research worldwide, portfolio of 800 to 900 million per year. Limited data available to really look at, but about 15 million funding in hepatitis over the last 10 years, so less than the MRC. And in terms of active funds, it's really looking at about 7 to 8 million. Hep C, twofold compared to hepatitis C. But what's striking is that this constitutes 1.5% of the infection immunity portfolio, not of the whole research funding portfolio, but of that specific budget. But I think the real caveat here is that a lot of the international work that is done in the Wellcome Trust Overseas Centre is not captured. So I think this probably represents not a true picture of the investment. Just one slide on ARNRS, because Claire will be speaking to this. So a major funder of HIV, hepatitis B, hepatitis C, as well as in lower middle income countries. These two pie charts show the total annual ARNRS budget, 44 million in 2012, increasing in 2014, and importantly, an increase in the hepatitis component of that from 8 million to 14 million. Although this was largely accounted for by a single sort of cohort taking up 30% of the investment. And you can see the multiple projects across multiple countries. European Union, I think the much touted, we invest 42 million euros over 7 years is perhaps a little misleading, because this includes work on transplantation, cirrhosis, alcoholic and non-alcoholic liver disease. Probably really the true figure is more like 9 million invested in 3 major projects. And just to highlight the flagship Prolifica project, which I just attended on Tuesday, some of the feedback of the results as they come to a close. So this is the study on the prevention of liver fibrosis and liver cancer in Africa, based in the Gambia unit, with 2 main objectives: population screening for hepatitis B and tenofovir treatment, and a case control study of hepatocellular carcinoma. So lots of prolific outputs from Prolifica, and there has just been another call for 9 million in the third health programme. And I understand from colleagues that everybody is going to be diving on this 9 million, so highly competitive. So now moving across the Atlantic, looking at the NIH, and you can see almost immediately massive fold increase in the overall level of funding from the 6 different NIH agencies, so around 200 million a year. Looking at the bar chart down there on the left, some evidence, if you look at the blue, of an increase over time, the yellow versus the grey, Hep C versus B, so much as we've seen for others. But I think the main sort of key message, looking at that little slim bar chart, is showing the relative funding for HIV way up there in the yellow, tiny little dots at the bottom for hepatitis, so 120-fold higher for HIV. And many thanks to Ben Cowie, who shared this slide on the situation in Australia. So pretty similar HIV versus hepatitis, although not quite so marked. CDC, which is of course a public health agency and public health research funding, 20 million in 2014. Thank you to John Ward for sharing these slides. And again, as others have seen, hepatitis C funded about 3-fold higher than hepatitis B. And this just highlights some of the technical assistance projects going on in different countries. In Georgia, support for the elimination project; Egypt for the development and implementation of the comprehensive plan, with a demonstration project in Aswan, and work in hepatitis B in Vietnam. So just to finish in the concluding slides, and moving to the really important and emerging area of how to make optimal use of the observational and so-called real-world cohort data, as well as the countless new demonstration, pilot, and implementation projects that have been set up, which are funded from a wide variety of different sources, many of it sort of national government funding. And this just highlights, an example: an international registry, HCV Target, the Egyptian National Database, which is phenomenal. But I think it's fair to say that some of these, particularly the cohort studies and registries, are often not really real world. Patients are highly selected. The data is often not captured in a way to address the programmatic issues of loss to follow-up, adherence, retention, and discontinuations, and doesn't optimally link to other databases to really assess the national impact of expanded care and treatment, so mortality, hospitalizations, liver cancer. So just to flag quickly, the Some of these other implementation projects, so first the UNITAID-funded MSF demonstration project in MSF HIV treatment sites, 50 million over 5 years, 7 countries in the first instance, with multifaceted interventions, and the main objective being to demonstrate feasibility of treatment with DEAs as a precursor to wider uptake, and trying to really leverage the lessons learned from scaling up ART. A similar initiative implementation project is that of a DFID-funded program for the Clinton Foundation of implementing in the potential countries being Rwanda, Myanmar, Nigeria, Vietnam, Indonesia, India, and Ethiopia, with the main objective of generating evidence for scale-up. So by simplifying the diagnostic and treatment algorithm, integrating hepatitis C into existing diagnostic networks, but also at the same time, like the MSF project, addressing the other roadblocks, how to facilitate fast-track registration, which came up many times in the treatment access parallel session yesterday, and supporting country financing efforts. So just to finish with, what are the public health research priorities? Well, WHO has not to date undertaken any systematic or comprehensive approach to research priority setting. We can discuss in the questions and answers about whether this would be valuable. And there are many different ways to cut the pie and to categorize. And I've just flagged 3 areas that I think probably we would all agree would be important. So just moving to the final slides, I think improving the quality of testing technologies, algorithms, and services. So what are the most effective and cost-effective testing strategies and diagnostic algorithms to improve the uptake of testing and detection rates in the wide range of different populations and settings? The need for rapid, low-cost point of care, serologic and molecular tests, and also not forgetting hepatitis delta virus. And the real need for just basic descriptive population-specific data through surveys and special studies on patterns and modes of transmission, rates of vaccination, testing, linkage to care, and treatment. Second, develop, adapt, evaluate, and compare different models of hepatitis care and treatment along the continuum of care, so different models of decentralized and integrated care in diverse populations and settings, so the hard to reach, the hard to treat, and how to best analyze data from pilot and demonstration projects. The need for standardized case definitions, some core data sets and core data collections so we can compare across these different populations, programs in different countries. And the need, of course, for qualitative research to better understand the barriers and facilitators along the continuum of care. Just to flag some of the key treatment strategies, as I've mentioned, the need for design and analysis of rigorous prospective real-world cohort studies that look at both early outcomes, long-term outcomes, patient-centered outcomes, and in hepatitis C, comparative trials still are needed, looking at the difficult-to-treat populations, and of course, moving the treatment prevention agenda to some formal studies above and beyond modeling. And for B, the need for curative treatment trials as well as management of Delta and the efficacy and safety of mother-to-child transmission. So I'm now going to hand over to Claire. These are some of the flagged topics for discussion. We will start with targeted questions to the panel and then open it up to the group and look forward to it. Thanks very much.